Okay, great. So we're going to talk about establishing a pain diagnosis, and I'm really going to be focusing predominantly on the typical primary care practice. I've got no specific disclosures. I will maybe talk a little bit about pain treatments, but there's limited evidence-based support for much, but enough to be able to make sense of it all. So basic objectives today are that one, chronic pain, quote unquote, is not an adequate diagnosis that will lead to successful treatment planning. Two, that we're going to walk through a systematic characterization of painful conditions. Commonly presenting chronic pain conditions will follow with a structured approach. And then very importantly, since pain is a social and psychological as well as a biomedical problem, to be able to identify those the behavioral health components that are significantly contributing, and the need to reevaluate if the clinical presentation changes over time, and then the need to counsel patients and caregivers about treatment side effects. So the first thing I want to talk about is the state law here in Washington. I know a number of you are from Idaho, but the state law is pretty specific, and I've highlighted, you can read all the details, but what I've highlighted at the bottom is that the health record should include a diagnosis. And I think this is quite ordinary for primary care providers to know what the diagnosis is before they treat. And a chronic pain, quote unquote, as the diagnosis is not sufficient. I like to say it's like identifying someone with dropsy, which is the old-fashioned term for congestive heart failure, which of course differs from all the other kinds of cardiovascular diseases that can cause edema or consumption, which used to describe tuberculosis. But we are in the 21st century and we need to do a more precise diagnosis just because we are trying to be conscientious clinicians. So a few words of definition that will allow us to frame the diagnosis. First is, what is the characteristic of the pain? Is it acute or is it chronic? And this is very important because we have certain expectations of acute pain. The most important one is that it is a self-limited condition, that acute pain represents an injury or damage to the body in one or any number of sites that will be expected to recover. So acute pain is by definition transient because if it lasts longer than 90 days, it's by definition, most people would define it as chronic pain at that threshold of 90 days. The source most often is identifiable. There's a broken ankle, there's an inflamed gallbladder, there's a surgical wound. So we have a pretty clear location and it will resolve. So our treatment of acute pain is expect cure, allow the patient to move through rehabilitation and carry on with life as they can best manage, and suppress pain as required. So definition of acute pain. So chronic pain is very different. Chronic pain is not persistent acute pain. It needs to be viewed as a completely distinct diagnosis. By definition, it's longer than 90 days or 3 months. That is a timeline definition, but largely most tissue injury disease states, when treated properly, will recover after 90 days. And more importantly, the central nervous system becomes altered. The continuous input of sensory signals from pain-inducing triggers, we call that nociception. So persistent nociception will change the central nervous system because it is a plastic system that responds and adapts. Unfortunately, chronic pain is a maladaptive phenomenon that affects not only the physical, but the psychological and environmental factors that layer into patients as they move forward with their pain condition and as they often fail to move forward in their lives. The treatment goal is distinct. It is not about getting someone through the acute phase. It's about improving function and quality of life of the patient. It's a rehabilitation model that de-emphasizes pain intensity and focuses more on function and quality of life. A couple other definitions that are useful, and this is how you would define it: acute pain diagnosis X, chronic pain related to fibromyalgia, or chronic pain related to diabetic peripheral neuropathy, or chronic pain secondary to chronic daily headache disorder. So those are the characteristics of chronic versus acute. Nociceptive pain, as I mentioned, is pain arising from typically damage. Even the threat of damage can activate nociceptors. It relates to the activation of nociceptors. It has certain characteristics. I've listed them here. This is the standard pain complaints that we'll hear from our patients who have ordinarily musculoskeletal or any other post-traumatic injuries. They occur, as mentioned, in musculoskeletal conditions, muscle, ligament, tendon, spine, so disc, facet, compression fractures. Visceral structures have nociceptors as well. Duodenal ulcers, perforated gallbladders, appendicitis, ovarian cysts. These would be visceral pain syndromes. They are nociceptive as well. And headache does have a nociceptive feature because there's an inflammatory state generated by the neurological trigger. Temporomandibular joint disease, dental pain, and what we call cervicogenic headache, pain deriving from structures in the neck, such as degenerative arthritis. These would all be characteristically nociceptive pain. Neuropathic pain refers to pain that is caused by a disease or injury of the somatosensory nervous system. It could be the peripheral nervous system or the central nervous system. So the PNS or CNS can be involved. Its characteristics are different. This is the burning, the electrical, the shooting discomfort. Pins and needles may be present. The normal nervous system extinguishes repetitive stimulation. So an exercise for those of you who are falling asleep because you didn't get a good night's sleep, or I'm stupefyingly boring, one or the other, I would suggest a quick exercise of just tapping the back side of your hand very lightly, enough to feel it. And you do that repetitively. And if you keep the same amount of touch sensation going, the sensation will tend to lessen. The body gets used to it. Another example is sitting. If you think about your buttock while you're sitting, you'll actually feel it. But over time, the summated feeling of the sensations that are entering through the buttock nociceptors will diminish until you won't even feel the fact that you're sitting in that area. So the body reduces that. In a neuropathic pain state, the body summates it. So instead of lessening, it will tend to augment. So this is a very useful clinical diagnostic tool to evaluate the difference between nociceptive and neuropathic pain, because nociceptive pain will hurt. You keep tapping it, it tends to stay the same. Neuropathic pain will often augment in response to the repetitive stimulation. Neuropathic pain, though it's not part of the neurologist's lexicon for neuropathic pain, there may be autonomic features, vasodilation, color change, sweating changes, and the like that may also occur in neuropathic pain, such as you might see with complex regional pain syndrome or CRPS. Sometimes people with radicular back pain may have color and temperature and sometimes edema in the affected limb that's not as dramatic as CRPS, but that's involvement of the sympathetic nervous system because at that point in time when it's gone on for a long period of time, that neuropathic pain will become centralized and the more aspects of the central nervous system, including the sympathetic nervous system, become recruited. Characteristic diseases that have neuropathic pain are neuromas, entrapment syndromes, postherpetic neuralgia, the polyneuropathies that may be associated with B12 or folate deficiencies, toxins, paraneoplastic syndromes, i.e. malignant causes, infection generalized neuropathies, that would be like Guillain-Barré syndrome or post-Lyme neuropathy syndromes. Central pain syndromes, MS, important to know is MS presents more times than not as pain. That is contrary to the education I had or the hidden curriculum that I heard over the years. That pain is often a characteristic symptom, but it follows the same course of episodic, periodic, and switching locations from one to the other. And the descriptors are often very neuropathic. spinal injuries, spinal cord injuries, or spinal root damage from a herniated disc that you might see with radiculopathy. And I've already mentioned complex regional pain syndrome, or CRPS. Visceral pain, another category of pain syndromes, is a consequence of some disease or damage to a visceral organ. Visceral pain, typical pain, it would be acute coronary syndrome. So angina, referring is one of the characteristics of visceral pain. Visceral structures have three components of the nervous system: the segmental level above and the segmental level below, plus that primary segment, plus the autonomic nervous system is involved in visceral pain syndromes routinely. This is why it's difficult to locate, because you've got three segmental areas involved, and why there's often nausea, a sickening discomfort that's associated with many of the visceral pain syndromes. And vomiting may also be characteristically seen with visceral pain syndromes. We see these, again, as mentioned, ischemic cardiac disease. Pneumonia can sometimes refer to the right upper quadrant, particularly in older patients. Pulmonary emboli, you can read the list. Internal organs that are acutely damaged. In chronic states, inflammatory bowel disease or irritable bowel syndrome, both of the IBSs are present. Interstitial cystitis, chronic pelvic pain, these become chronic states that are visceral pain syndromes, and also acute on chronic. So inflammatory bowel disease, episodically occurring, so that's acute pain, but with chronification, it becomes a chronic pain syndrome, so you've got acute on chronic pain, often seen with inflammatory bowel disease and recurrent pancreatitis. So what I've done here is I've given you a list of categorizing pain, but also the different kind of pain syndromes. So the word chronic pain syndrome all by itself is simply not adequate for treatment planning, nor by most guidelines that do explicitly recommend that a diagnosis of what the pain is like. This complicated slide I'm sharing with you right now, I think is excellent. I pulled this together from a recent article from Steve Stanos, from our colleagues at Swedish, and a national group talking about rethinking chronic pain in the primary care setting. In this diagram, at the top are the neuropathic pain syndromes, a sampling. On the left are the predominantly nociceptive pain syndromes. These are more commonly seen in more difficult to manage patients with chronic pain. The predominantly nociceptive pain syndromes will respond to opioids, unlike the predominantly central sensitized syndromes, which are on the right in red, that will not respond to opioids. So this will help us make a differentiation of what type of treatment that we will be able to select that will be most responsive to the type of pain. Dan Claw, who contributed this article, in the center overlap of the Venn diagram, he demonstrates what you actually see in real clinical practice is an overlap, because acute pain, when it becomes persistent, sensitizes the central nervous system, so you get both nociceptive pain and hypersensitivity, and often neuropathic pain syndromes will do the same and present this overlap syndrome. So locating it precisely is less important than recognizing the broad categorization of that pain state. I present here a brilliant work by Muhammad Yunus. Back in the mid-90s, he, as a rheumatologist who was studying fibromyalgia, began to identify that fibromyalgia does not appear to have peripheral nociception present, but in fact it's a disorder of pain processing, that the central nervous system is experiencing non-painful stimuli as painful. That's why it's hyperalgesic. And how do you account for that? Nothing can be found in the periphery significantly. There's some small fiber disease that may turn into fibromyalgia, but disease fibromyalgia does not have peripheral nociception. Similarly, irritable bowel syndrome, tension headaches, migraine, temporomandibular disorder, myofascial pain syndromes, chronic pelvic pain, and chronic bladder pain syndromes in both men and women are all examples where there is no longer active nociception necessary for the pain to persist, and hence it is central. In other words, central nervous system disease, not peripheral. So our targets for treatment, our management strategies differ dramatically. Complicating pain, the biopsychosocial, is the psychological impact of having long-standing pain. So many patients will have an anxiety disorder, which you can evaluate with the GAD-7 or the PHQ-4, which is the tool we're sharing with you for your presentations. Depression, a PH9 or a PHQ-4 again. The PHQ-4 has 2 from the GAD-7 and 2 from the 9, hence the 4. Or post-traumatic stress disorder. In our clinic here, 40% of patients have generalized anxiety disorder, 55% have major depression, and 30% have PTSD. And I would hazard that in your practice, you've been seeing these diagnoses and simply not making the accurate diagnosis because you've not measured and evaluated. Just like you'd evaluate a fracture with an x-ray, you evaluate anxiety by not just asking the patient, but getting some more objective, granted it's a patient-reported outcome, they describe the symptoms. But this will allow you to establish a diagnosis of anxiety, depression, or PTSD much more effectively. And this would be part of the diagnoses that are associated with your pain syndrome. There's also medical conditions that would be important to identify in the setting of patients with chronic pain, particularly when you're selecting treatment. Are they sleep disorders? And this is why we often ask on a 0 to 10 scale, how does pain interfere with your sleep? That may be useful, but the patient may also have central sleep apnea or obstructive sleep apnea, or both. The stop bang, I've given you the questions to identify that can help you make a diagnosis. A score of 3 or more is a high correlation with a polysomnographic diagnosis of obstructive sleep apnea. But central sleep apnea has no screening measures. In many patients, particularly those on high-dose opioids, and that means an MED above 100, or opioids and benzos combined will have central sleep apnea, for which the only treatment is eliminating the cause. We can see from a little bit of science here, Walker, now 9 years ago, identified a morphine equivalent dose increase that's associated with the development of sleep-disordered breathing syndromes. And this top graph is an indication of central sleep apnea, which you can see is much more sensitive to the impact of opioid exposure than the triangle here, which is the obstructive sleep apnea. Now, here's a 20% increase of obstructive sleep apnea with an MED of about 150. Other studies showed closer to 100, but at least a 10% increase. But this is substantially increased, a 3-fold increase in the incidence of central sleep apnea. And then co-prescribed sedatives, benzodiazepines, or soma, carisoprodol, or probably the muscle relaxants, you're likely creating central sleep apnea and don't even recognize that. Identify addiction, another co-occurring condition. Perhaps 20% of patients on opiates for chronic pain have a co-occurring addiction diagnosis. We can spend a separate time on this in the different webinars, but misuse, abuse versus addiction needs to be managed. So in conclusion, quoting the very famous William Osler, in order to treat something, we must first learn to recognize it. And I'm going to propose that this 19th century idea that if we make a diagnosis, we'll do a whole lot better job providing effective treatment, still applies in the 150 years later, that the diagnosis will precede treatment. And importantly, in chronic pain, it is complex because there are multi-dimensions. But if you followed a structured approach, categorizing acute versus chronic, neuropathic versus nociceptive, central sensitization involved, and identify a clinical diagnosis that supports that, your treatment and the outcome of your patients will be dramatically improved.